You might have noticed a name resemblance in one of your adult advisors. So I'm Mr. Koch's son. Some of you might recognize me. I think I was here 2 or 3 years ago. I know some of you guys look familiar to me. So I just want to say to start out with, I love coming here. One, you're probably one of the smartest audiences I talk to. I am an instructor. I teach for the U.S. Air Force as well as doing some other things and here and there. But I came up through this program, and I have nothing but positive things to say about it. I might get a little choked up because it's a pretty powerful place. This is probably to spend more of your time than I'm sure you want to spend on something that you get to deal with every day. But this is one of the best experiences you're going to have in your life. And if you can make it here and do well, you're probably going to not have that many problems doing well moving forward, because you have to worry about discussions and meeting conflicts and all this stuff. So it teaches you how to be a good provider, but it also teaches you how to really do a good job as far as your career goes, leadership, everything. So I took a lot away from this program, and I hope you guys take advantage of it while you're here. I've been recently sort of reviewing my current job's mission, vision, and values, and things like the 8 words. And every company has them, but this place actually uses them. You embody them every day, and it's awesome. So, anyways, enough about that. A couple things. I hope for this to go about 30 to 40 minutes. If you start to get bored or you have a big test, pull out your phone, fall asleep, text your friends, just let me know. I mean, just make it clear. I'll see that you guys are starting to nod off and we'll move this along. So I know what this is like, especially if you have like a calc test tomorrow morning, thick day. A lot of respiratory emergencies, but you got to pass calculus. So, all right. Okay, so we're going to start out with this video. I was recently just taking a trip down memory lane. This is a video from 1991 that features the post, and this is a little quote from my gene pool here.
A mock accident. But how does it compare to the kid's performance in a real accident? Do they ever lose it?
The kids never lose it. When that beeper goes off, the kids stop being kids, they start being adults. And that's when performance and saving lives really begins.
Don't expect anything out of this training meeting that's as good as that. It's a hard act to follow, but I'm going to do my best. So, I mean, that's what we're here for. We're here for performance and saving lives. So that's what my goal is for us to do as a group with these different scenarios as if they're real. So who am I? Okay. So my job currently, I work as a flight nurse and flight paramedic for Dartmouth-Hitchcock, which is in the middle of New Hampshire. And so we provide care basically to the entire state of Vermont, New Hampshire, as well as parts of Maine and New York. For anyone who's sick, no matter what it is, no matter how sick they are, we're the people you can call. So this is me at my day job. This is really me. I ate all this candy before I got here to get psyched up, to get you guys psyched up. I look 12. I'm actually 28, but I'm just a kid. So I got here just like everybody else. And this is my ambulance, and it's pretty nice. It goes a little faster than yours, so we don't have to obey a lot of traffic laws, which is pretty sweet. This is the inside, so it's pretty cramped. And the only reason I show you this is because everyone just wants to see pictures of the helicopter. I don't really care what it's like. Okay, all right. So what we're going to go over. So we're going to go over respiratory distress, treatment, and anatomy. And we're also going to look at several real-life case studies. These are all patients that I've taken care of either as a flight medic, flight nurse. I used to work in the ICU for 4 years, or when I worked as a paramedic in Norwalk. So we're going to look at them and we're going to evaluate whether they're stable or sick, and then we're going to try to look and figure out what's going on. So we're going to use a patient's presenting signs and symptoms, their medical history, medications, and vitals to focus our differential diagnosis, and I'll explain what that is. Okay, some definitions. So what causes a patient to be short of breath? Okay, obstruction of airway. Perfect example. What, at like a broader level, causes patients to be short of breath?
Lack of oxygen.
Lack of oxygen, absolutely. I should have given you these slides ahead. I'm doing great so far. So basically, you're not getting enough oxygen to your end organs or your cells. And so your system compensates. It notices in your baroreceptors that in your aortic arch and then in your carotid arteries that we're not getting enough oxygen, guys, and we need to do something about it. So that leads us to this, hypoxia, a condition in which the body cells and tissues do not have enough oxygen. Now what's something that's pretty similar to hypoxia in terms of end organ perfusion? Shock. Awesome. Right? So that's hypoperfusion to the cells in the body that causes organs and their organ systems to fail. So these things are intertwined. And the reason I bring this up is that at a basic level, it doesn't matter what's going on with your patient. They're not getting enough oxygen to the end organ or their cells and tissues. So we need to treat that at a basic level, but then we need to figure out what's going on, like an airway obstruction, like you were saying before, and then treat that specific thing. So we're going to sort of look at that from a two-pronged approach. And differential diagnosis. This is the process of differentiating between two or more conditions that share similar signs and symptoms. That's a big fancy word a lot of physicians like to use. Basically, we're trying to figure out what's wrong with our patient specifically. So you get there, they're short of breath, you start out there, and then you need to figure out that their airway's obstructed. It doesn't matter what else you do, if you don't figure out that their airway's obstructed, then you're not going to get anywhere fast. So as we go through these scenarios, we're going to look at things and try to narrow down exactly what's going on. So basically, it's what you think is wrong with the patient. And so the final thing is we're all healthcare providers. So there's multiple different levels in here: nursing, EMTIs, so people that are on paramedic tracks are paramedics, EMTs, first aid graduates, riders, but we're all getting to the same goal, which is the best patient care, and the better we do with our job at any level is going to make that care better for that person. So it doesn't matter that I'm only a first aider, I'm only a rider, I'm only an EMT. Even though your scope might be small as a first aider, that you need to apply direct pressure and call for help, or as an EMT, you need to assist the patient using their EpiPen or give one that we have. The better you are with your assessment is going to make a difference. And so you don't need to be limited by your scope to limit how good and quality your assessment is. You can have the assessment level of a physician or a nurse practitioner and still just be an EMT. So that's why we always can learn. It's not, I'm just a nurse, which I hear a lot, in my civilian job, my other job, because the doctor's diagnosed. So I'm going to try to get out of that, stay out of that trap. Here's just another picture. Everybody's psyched up. We're going to do things. We're going to fly into this material. So this is your standard picture, requisite picture of the cardiovascular system. And so again, the only point in bringing this up is that it doesn't need to involve the lungs necessarily to cause someone to be short of breath. Can anyone name something that might cause someone to be short of breath that has nothing to do with the respiratory system? Perfect. Congestive heart failure. The heart's failing, and then because of that, you're not getting enough oxygen to the tissues. Absolutely. So it causes respiratory distress. You named one. I won't have you guys go through it. We have a lot of them, right? Foreign body airway obstruction, number one list. Great job. So then we have hepatitis, croup, asthma, myocardial infarction, pulmonary edema, pulmonary embolism, hypovolemia. That last one, anxiety. So no matter what's going on, you can make the patient worse by not being cool, calm, and collected. I have a friend who's now in med school. He used to work with me as a paramedic in Norwalk, and he used to say that paramedics are often wrong but never unsure. Now this is sort of a knock on the profession as a whole because we are somewhat cocky as a profession. But the other thing is that we always need to display an air that we know what's going on. Everything's going to be okay. We're the calm in the storm. So I was up here as we were prepping these slides, and I heard Mrs. Gilday said, running, well, I don't know what I did there. Okay. Running is not what we do. We're going to walk, we're going to be calm, we're going to be professional. And that's, absolutely the case. One, because medics are lazy and we don't want to have to run on the 7th call of the day, but also because no matter what's going on, everybody's going to be freaking out, but you got to be calm. You got to be there and say, okay, we're going to get through it. So here's our lung anatomy, and so this is where we get into our more focused assessment and start looking at what's actually going on with our patient. So we've given them oxygen, we've treated for shock, we're doing these things, and we're starting to create our differential diagnosis, which is, again, just a big fancy word for trying to figure out what the hell's going on with the patient. So we're going to listen to lung sounds, we're going to do all these things to try to focus our exam so that we can figure out what's going on and then treat that. So is there anything that we can, do we have medications that we can treat anything that's wrong with this stuff? Oxygen, okay, great. What's one other medication that we can assist a patient with that they take themselves? Albuterol, yeah. So we have medication that we can treat some of these things. But albuterol can be bad if we're giving it for the wrong reasons. So we want to try to narrow it down and figure out what's going on. Okay. So some treatment. Okay, so we're going to treat our ABCs, our life threats. So we're going to stop any obvious major bleeding. We're going to make sure the airway's open. We're going to make sure the patient's breathing adequately, whether or not they need a bag valve mask. We're going to treat for shock. We're going to start doing some other stuff. We're going to look at their vitals, their present illness, medical history, their medications, create our differential diagnosis, and then perhaps start transporting, or if we're waiting for a medic or whatever and we're still on scene, start to treat that differential. So if that patient was having an asthma attack, we might give albuterol, as we were sort of talking about before, and they weren't enough. Okay, so what are these three things? History, present illness, medical history, medication. What do those make up? What mnemonic do we use to remember those and some other things? Sampling. Yeah, perfect. So nothing I'm saying here is actually really new. It's just new to look at. So everybody remembers this thing, some people have nightmares about it. So this thing on here, I know it's hard to read, it says, state field impression of patient. So what's that? Yeah, our differential diagnosis, right? I'm just using a big fancy word because I have to look in front of you guys. It's hard to press you guys, so I'm trying to use big words. And interventions, we're going to start to treat that. So we're doing this already in our exam. We're just going to try to focus more on it and figure out what's going on so that we can improve our skills providers and give better patient care. Okay. Another picture, a rough day at the office. Okay. So now we're in case studies. Sort of the end of me lecturing. I gave you some basic tools. The toolkit, we're going to walk through this together. You guys ready? Yeah. All right. Anybody falling asleep yet? No phones out. Saw one there. Okay. All right. So this is an easy one. We're going to start it off and go kind of fast. So we're called to a home at 5 a.m. for a 74-year-old male patient complaining of shortness of breath and chest pain. So what are we thinking right off the bat? What are you thinking here?
Having trouble breathing.
Absolutely. Absolutely. It's a good guess because it's a respiratory lecture, so you can't go wrong with that. I like it. I put you on the spot. Way to get through it. Okay. What else do we think? What might be going on with this patient?
MI.
MI. Yeah, they're having an MI, right? Their chest pain. That's what we're thinking off the bat. So are we thinking initially, is this patient sick or not sick?
Sick.
Potentially sick. Yeah. And so you guys have automatic dispatching for your paramedics, right? Is that the case? Yeah. So you don't have to call anymore and say, if there was always funny, yeah, send the medic. Start a medic my way. That's right. It was not bad. So if we weren't to have that, we might start a medic for this. That would be appropriate based on at least our dispatch information. So you enter in front of the patient, trying to get dressed in their Sunday best. Does everyone know what I mean by that? This is like an 80-year-old guy. He's got a bow tie on at like 5 in the morning. He knows he's going to the hospital, but he's got to look good. So he's diaphoretic and he's frequently stopping to catch his breath. So has our field impression changed at all? Is this person still look sick? Yeah, they still look sick. He's not like just sitting there, playing with his phone, hanging out. He's, he's diaphoretic, frequently stopping to catch his breath. Okay. We're thinking, any new ideas for what could be causing this? We're still thinking MI. Yeah, it's still thinking MI. You have nothing to say that it's something else right now. No new information that's changing the way you're going. Right? So our assessment, the patient's complaining of chest pain, radiating down his left arm. He's alert 9 times 3 and his lungs are clear. So what are we thinking? Still MI? Still a good possibility for this? Yeah, right? Chest pain radiating down his left arm. Cardinal sign of an MI, especially for males. Women obviously present differently. Sometimes fatigue is their most common sign. Sometimes it's pain between the shoulder blades. You guys got to watch out because no one's studying you because it's a harder demographic and whatever. Research, get into it later. Nursing thesis down the road. Okay. And their lungs are clear. So do we think something's going on in the pulmonary system by itself?
No.
I wouldn't say so because you're going to hear that their lung sounds are compromised or different in some way. They might be decreased, they might have wheezes, they might have rales, bronchi. But if they're clear, there's probably nothing wrong right there. And so the reason of their shortness of breath in this case most likely is not in the respiratory system, but it's in that bigger picture, that cardiovascular system. When you're saying pulmonary edema or congestive heart failure or something, you should take credit for it, you're allowed to. You know, that something was going on not in the respiratory system. So yeah, I'm still on board with you guys. I still think I'm fine. Okay. So these are his vitals. Blood pressure of 160 over 92. High, low, normal.
High.
High. Pulse of 92. High, low, normal.
High.
High. Respiratory rate like 24. High. All right. So medication: aspirin, nitro, Coumadin, digoxin, simvastatin. So what's aspirin for? What do we use it for?
Blood thinner.
Blood thinner. Okay. It decreases the ability for platelets to bind to one another, so it's a blood thinner. What else do we use it for? Anti-pain, yeah, anti-emetic or analgesics, excuse me. So, you know, pain medication. But yeah, it's often patients who take it every day or taking it for, you know, some risk of some heart history. Nitroglycerin, what do we take that for?
Angina.
Angina, yeah, chest pain. So again, cardiac. Coumadin, what's that? Blood thinner, okay. Digoxin, anybody know what this is?
Slow the heart rate down.
This is still there.
Cardiotonic.
Cardiotonic. So it increases how hard the heart's pumping and decreases how fast it's pumping. So we often see this with atrial fibrillation, which is an arrhythmia of the heart that's often seen in older patients, and it's a risk for several things. But again, coronary issue and simvastatin. Does anyone know what that is? Cholesterol medication. So all those medications that end in statin, those are all for cholesterol. So anytime you see a statin, cholesterol, when we think cholesterol, I think heart, because it has to do with the arteries hardening and plaque building up and not limiting the blood flow. Okay. So we still thinking MI?
Yeah.
Yeah, absolutely. Okay. So he has a history of an MI 6 months prior. So is this, are we, you know, starting to think that maybe we're going down the right path with this? Yeah, I would say so. I mean, if you hear hoofbeats, don't look for zebras, you know, look for horses. Everything's pointed towards MI. You know, it's probably a safe bet to say MI. This isn't the time to pull out your, I think it's pericarditis. Sure. You know, I mean, you can, but, you know, everything's sort of looking that way. Okay, so our differential diagnosis, what we think is going on with this patient, MI or angina. Okay, so our treatment, high flow oxygen, rapid transport, and you make sure he has 324 milligrams of aspirin. We might help him with his own nitroglycerin sublingually, up to 3 doses. Is that still? Everybody correct me if I'm wrong when I start, you know, going away from the protocol or stuff like that. So, medic intercept, absolutely. They're going to do a 12-week EKG. They're going to probably give Plavix, which is another medication to inhibit platelet binding or blood thinning. Beta blockers to help control the heart rate and how hard the heart's working, relieve the workload on it. They might give medications to break that clot, or clot causing medication, and then eventually, hopefully, they're going to go to the cath lab, especially here, both Stanford and Norwalk have primary angioplasty. So they're going to go in, balloon open that vessel, get blood flow, everyone's happy, yay, we won. Newspaper article, high five. All right, everybody know how this is going to kind of go now? So everything's going to sort of flow like this. Okay, all right, cool. Okay, so this is a 12 lead. It's not from him. It's just a random 12 lead. Does this thing have a laser pointing on it? Okay, all right. So see this part here where it's this little thing isn't coming down to this line here? So this is, yeah, ST segment elevation. Yeah, absolutely. So in this case, we see elevation in lead 3. We see it again in AVM. And you see some other changes, but this is indicative of the inferior wall MI, which is basically just a part of the heart, the bottom of the heart, and sometimes wraps around to the back. So we sort of know from this that yes, indeed, this patient is having a heart attack and they need to go get a primary angioplasty. And you also see that this part down here is ST depression is sort of similar to what this young man was saying. So this part here doesn't get back. And this is just more for fun. If you're like an EMS nerd like me and you're folks that you were trying to tell the medics that this was an AFib and they said, no, your cables are just leaking. So basically, when we're looking at this, you have a Q wave here that dips down, and the R wave goes up, and this is an S wave that dips back down. When we're talking about the letters, that's the farther wave. And again, it's just a little fun for me, hopefully fun for you. Hopefully it's case study. Okay. Case number 2. So you called to a home at 4 p.m. for a 35-year-old female, shortness of breath on a humid, warm spring day. So what are we thinking here? What are we thinking off the bat?
Asthma.
Asthma. Great. What else might you be thinking of?
Some kind of obstruction.
Anxiety, heat exhaustion, anaphylaxis, allergic reaction. Yeah, I think all these are great places to start. And again, if we dispatch your own medics, which you don't be, you have automatic dispatching through CMed, awesome, those guys are great, then you don't have to worry about it. But I would think all those things. So that's what's sort of going through my head as I go to this call, sort of tracking for that. Okay. So you enter and find the patient sitting in a chair, tripod position. Can you show me what tripod position looks like? Beautiful. They're flush, they're stating intuitive word dyspnea that she can't catch her breath. The patient has audible external wheezes, and her husband states she's used her inhaler several times without improvement. So now that we had all those things, we had great, possible differentials at the top. We had heat exhaustion, we had anaphylaxis, we had asthma, we had, what else? We had just environmental emergencies. I think I'm against business on environmental emergencies, that's a little vague, but, so we have all these things. What are we thinking now? Asthma. Yeah, I would agree. If they looked like that, but they weren't using their own inhaler, I might say anaphylaxis. But because they have their own inhaler and they didn't give themselves an EpiPen, I'm starting to think asthma. And we know something's going on with the pulmonary system because we have lung sounds that are different than normal. Okay, great job. So vitals, blood pressure 140/90, higher or low? Pulse of 120, high or low? Respiratory rate of 28, high or low? So is this patient sick or not so sick? Sick. Yeah, absolutely. And so when is this patient, how do we know if they were really sick? What might be an indicator that they were really not doing well? Sweating. Yeah, absolutely. So instead of seeing them breathing really fast, now they're breathing slow. So that's really bad. So they're not compensating for what's going on anymore. They're exhausted. One of the other things that you might see is, sorry? Yeah, absolutely. They might be pale instead of flush, so they're not perfusing well. Decreasing blood pressure, same thing, so they're not compensating as well. And the other thing that I think of is that they're not wheezing anymore. You just can't hear anything. They're not moving any air. So the wheezing is bad. It's not good. We don't normally wheeze all the time. But it's still better than not moving any air. So when they're to the point that you can't even hear wheezes anymore because they're moving so little air through their airway, that is a huge problem, and that's absolutely a life-threatening, imminent emergency, and hopefully your medic is right around the corner because they're probably going to need to be intubated. So the medication they take, albuterol and ipratropium. So anybody tell me how albuterol works? Bronchodilator, right. So it opens up the bronchial tree and lets air out primarily. In the case of asthma, the problem is that they can't exhale well. And then ipratropium is another medicine called atropine, which is very similar to atropine. And basically, it also dilates the bronchial tree as well. So sometimes patients take both together, and that medication is called atropine or duomen. We have a history of asthma. We were dead on with our assessment, and our differential diagnosis, or what we think is going on, is acute asthma exacerbation. So our treatment, like we said, high flow oxygen, rapid transport, help them use their metered dose inhaler, medic intercept, and then they might continue giving albuterol, ipratropium, nebulizer treatments, epi, sub-Q, or epinephrine under the skin, similar to why we use an EpiPen for anaphylaxis. Magnesium sulfate, steroids, and then hopefully not, but intubation is sort of the last one. And so one of the other things that concerns me about this patient is that they've used their inhaler several times and it hasn't made any bit of difference. So if you come in and you're like, okay, well you've used your albuterol inhaler, let me give you another puff of your albuterol inhaler. That's probably not going to do anything because they've been trying it 6 times and it hasn't done anything. So you need to think outside the box and do something different, or if you're that next level provider, do. But if you can identify that this patient is sick, they've tried everything that we have in our ambulance or at our scope of practice to use, and we really need to move a little bit faster. Not run, if you don't run, but walk more quickly, not dog. Any question?
Yeah, why would the albuterol inhaler not work?
Well, that's a good question. Basically, their disease process at that point is so bad that it's doing everything it can to open up that bronchial tree, and it's just not enough. Mrs. Gill, did you have anything to add to
I
that?
don't think it can get in there either.
True.
Because if they're not moving any air, so you're not gonna be able to inhale.
And if they use it a lot, they might have built up a tolerance to that medication as well, so it's not as effective as it once was. Case study 3. Call to the home for a 45-year-old African-American male patient complaining of shortness of breath and pain. This is the only scenario that I put ethnicity in at all. So what road am I trying to lead you down with this? Sickle cell anemia. I've heard it a couple times. You guys familiar with this? So basically in sickle cell, you get these sickled cells that look like this. And when, most of the time when they either are dehydrated, which is normally something that starts their sort of pain cycle process of this, or when they get clamped down, their blood pressure increases, those sickled cells hit a bifurcation in the vasculature and they get stuck. And they don't flow through very easily and it's very uncomfortable. In addition to this, all those sickled cells don't carry oxygen as well, so they're not getting oxygen to their end organs. So they have two things going on. They're not getting enough oxygen to their end organs, they're not perfusing well, and it's just sort of painful in general. So yeah, sickle cell. And the patient's complaining of shortness of breath and pain, and that would be sort of along the same lines as that. So you enter to find the patient seated in a chair with a knee immobilizer on, stating he's 5 days post-op from knee arthroplasty. So we thought sickle cell right off the bat. Are we changing our differential at all?
Yeah.
Pulmonary embolism. Yeah. So maybe, okay, so we'll go back a step because you guys are good. Okay, so we'll just make sure, I'm on board with you guys that I can catch up to where you're at. So basically, this patient had just had surgery. Their knee has been up like this for like 6 days. And because they couldn't move it around, they had clots that formed in their legs. So blood gets back to our heart through our venous system by valves, and it also gets back by skeletal muscle contraction that helps push that blood up. So every time you walk around, your legs move, the muscles constrict, and blood helps get pushed back into the heart. Well, when your leg is seated or in a position where it's immobile for a long time, or any part of your body is immobile, like patients who are just bedbound in general, like used to take care of in the ICU all the time, they're at very high risk for this. So you have a clot there, and now they move a little bit, and that clot breaks off and comes up in your lungs and blocks your pulmonary artery. Hopefully it blocks it fairly far down in sort of the smaller pulmonary artery, and not like here where it's blocking the whole blood flow that goes in your lungs. So that's what's going on. Okay, so dead on again. Try to throw your curveball. Assessment. So patients in minor to moderate respiratory distress and their lung sounds are clear. So we think something's going on with the pulmonary system, the lungs themselves, their lung sounds are clear. No, but we do think that there might be a clot and that that's blocking blood flow in the pulmonary artery. So it's not in the lungs, it's that blood flow is constricted and not getting oxygen and organ tissue perfusion.
Where's the pain? Didn't say where the pain is.
I just threw that in there to throw you guys off from my initial thing so I could sort of hit two scenarios at once. That's all. There's no pain. I mean, there's pain in his leg. He had knee surgery. He's pulled up. His knee hurts.
So operative site pain.
Sure. Again, I just did that so I could walk you down one road and
We're on to it. We're getting on to it.
all right. So vital blood pressure 150 over 92. High, low, a little high. Yeah. Pulse 110. High. Respiratory rate of 24. High. And O2 sat at 88% on your American.
Not good.
Those medication they take, atorvastatin, what's that statin ending? Cholesterol, great. Heparin sub-Q, you
Yeah.
guys know what that's for? It's to try to prevent blood clots a lot of times. And if the patient already has a blood clot, they'll still get it. Sometimes they get it through an IV so that over time their clots end up breaking down. And that doesn't actually break down clots, but it sort of prevents any further growth of that clot, and then over time your body's breaking down. And then oxycodone, what's that for? So heparin sub-Q on this patient, perfect example. They're given it to prevent a deep vein thrombosis or DVT clot, or he already has it and they sent him home. In this case, he already had a DVT. He was sent home with a known DVT, and he was prescribed heparin sub-Q, and a visiting nurse came and gave it to him. And the oxycodone for your pain, the surgical site pain.
Thank you for clarifying.
So, told you that part. So our differential diagnosis, you guys are dead on pulmonary embolism. And so our treatment, high flow oxygen, rapid transport, medic intercept, 12 lead EKG, because sometimes you actually can diagnose these based off your 12 lead EKG. CT angiography, it's basically they inject a bunch of IV contrast into your vasculature and they watch it go through, and when it gets stopped by this huge clot, it doesn't keep going through the rest of the arteries, pulmonary tree, or pulmonary vascular bed, then they know that you have a clot there, and then you rule them for a pulmonary embolism. And then heparin drip. Sometimes they'll actually have to remove a section of the pulmonary artery. Sometimes they'll try to use clot-busting medication, but most often it's okay. So here's this 3-lead EKG. Anybody want to take a stab at what we're seeing here? There's a lot of artifacts, so don't mind that.
Widening PR interval. Or widening QRST? Something
Everything
looks wide.
looks pretty good to me, so we'll walk through this because we're doing okay on time. So we have narrow QRS for the most part. It's less than 3 boxes. The beginning of this P wave is the beginning of the R wave, is less than 1 big box. That's fine. These are basically marching out, so they're regular. We have this PVC here, so that might have been what you saw with that widening QRS. But basically, it's just sinus tachycardia. So they're just tachycardic, nothing special. And most patients who have pulmonary embolism, this is the most common arrhythmia that you see. It's just that they're sinus tach, which could be a gajillion of them. But this was their 12 lead. It wasn't actually their 12 lead, but this patient did have this. Basically, there's this thing called S1Q3T3. So in lead 1, you have an S wave. This is the QRS. So you have this S wave here. And then in lead 3, you have a Q wave. That's the Q wave there. And you have an inverted T wave. So you have S1, Q3, T3. And I couldn't remember this because I was like, is it S1, Q3, T3, Q3, S1, T3? I know I've heard of it before. I want to look like a rock star. I want to walk into the hospital and say, diagnose this pulmonary embolism in the field definitively. So I Googled it on my phone, and it turned out it was S1, Q3, T3, and I was right. And I was, yeah, I'm a medic. Pulmonary embolism. Case closed. This is one outside. You're probably not going to get dispatched to a ski resort, hopefully. That would be bad. You know, with the government shutdown, maybe. You know, expands, you know, increased area responsibility. You called the base of a ski resort for an accident. What are you thinking? I mean, that is something you guys do every day, sick or not sick. A pneumothorax, what about that? Nothing indicates that at all. Like we might be going down that road. I'm not going to say we're not. We'll come back to you. All right. Okay. So this could be anything, right? It might be, you know, they just hurt their knee. It might be that they're dead. We don't know. So you get here to find a patient on supine on a longboard, saying she has blood pooling in her chest. Okay. So what might be going on here? And what would we call that? Hemopneumothorax. Almost right there. You didn't have that additional piece in. I do call it hemopneumothorax. And you said right-sided. I'm guaranteed. Based on the accident, right-sided hemopneumothorax. I showed you my slides at that time. Okay. So the patient was snowmobiling. They fell off. They hit their right side of a chest on a rock. They were helmeted. And then they were extricated to the base of the ski resort. So it wasn't actually a ski accident. It just happened to be that there was a ski resort around the corner. They knew that this was bad, and they whipped her over there, and now she's in the back of the ambulance. So you find the patient talking in shortened sentences. Their diaphragm, their tail, the right side of the chest wall is tender, pure palpation. They're wearing a ski jacket, which really only matters for 2 reasons. Make your assessment harder because they have this layer of clothing. It's going to be painful to take it off to try to do a better assessment. And any of your interventions, you might need to remove it anyways. And if you end up cutting it and it's full of down, you will never get it out of the back of the ambulance. So most medics will tell you, cut anything, don't cut down. Just hold it out. Meaning one way or another, but you'll be covered in feathers. And it'll be really funny for everyone else. And their lung sounds are coarse. So if their lung sounds are coarse, do we think something's going on in their lung? Yeah. So they have paradoxical movement, subcutaneous emphysema, JVD. All these are signs of hemopneumonia that we virulently diagnosed with ESP right off the first line there. No, but having said that, I put this sort of in for you guys. I've had a couple patients that had pneumothoraxes, either tensions or spontaneous, and I've never seen paradoxical movement. I've never seen a flail segment where paradoxical movement where it's moving on its own. I haven't really felt sub-Q air. So a lot of these are late signs. Tracheal deviation, that's another textbook answer. But you're going to have to just be sort of on with your assessment. They have a right-sided chest wall injury. They're tender to that area. There's a significant mechanism involved. And I'm leaning towards it being a pneumo because everything fits. Everything fits my diagnosis, how it happened, it all makes sense. So that's where I'm leaning with this. I'm not sure. We're going to treat the general things, and if the patient gets worse, then we're going to have to do some other stuff or get a paramedic. So the blood pressure 90/60, high, low. Pulse of 140, high, low, high. Respiratory rate of 24, high. So this lady was actually an ER nurse, and she immediately said, "There's blood pooling on the right side of my chest." And I think she actually asked the crew to intubate her. It wasn't me. I took care of her in the ICU after that. But she was like, "I put a tube in my throat." So that's never a good sign when someone's asking to jam plastic down into their lung. Medical history is none. And we don't really expect it. It's otherwise healthy. I don't give you an age here, but let's say 35-year-old. So our differential, hemopneumo, flail chest, pulmonary contusion, all these things are big. So our treatment, surprise, surprise, high flow oxygen, rapid transport. We definitely want IV access, medic intercept. They're probably going to do a needle chest decompression. I'll get to you in 1 second. I see your hand. If they're capable in that system, or you have a flight crew that's on the way, which is the case in this instance, chest tube is probably going to get put in, especially for this because there's all this blood in the chest. It's not just that there's air in there, so sticking a little needle in isn't going to do much. And then this patient ended up getting intubated, and then you need to manage their pain, especially long term, because as they continue to have pain with that chest wound, they're not going to expand their lungs all the way, and then if they don't get intubated, then they might get intubated in 2 days. So we need to try to prevent them from splitting that injury and adequately control the pain. Again, we're not going to do a lot of that, but your medic would definitely, or should, hopefully do it. This patient actually, very sad story, was doing very well that night. I took care of her in the ICU. She had a large pulmonary contusion. After that, she had put in a chest tube. They put another chest tube on the other side. Pulmonary contusion is an injury that sometimes you don't see develop for about 48 hours. It takes a little time, and it requires a lot of oxygen and help to sort of split the lungs. But she ended up having a vertebral aneurysm and massive vertebral aneurysm, and basically had a huge brain injury, and they had to go through out there. So very sad. She was in the ICU and following all the commands. She looked good. She was breathing well on the bed. She was smiling. She was holding her fiance's hand. And then the next night I came in and she had this massive injury. Didn't see that one coming. No one really did.
Like a trauma agent, or was it?
They're not really sure. So to answer your question in a little bit more detail, normally, and you can always correct me because you're here and I'm just trying to get to where you are. But I normally see that with cervical spinal fractures. So her cervical spine was intact, there were no fractures there, and with the force that causes the cervical spine fracture, you also have jarring of those arteries that run up and perfuse the back side of the head. And they didn't see that, so they didn't do CT angio, and then this is what they sort of found later. There's really no indication. Really one more, let's see. Okay, we'll do this and we'll end up. Okay. So you called to the home at 7 a.m. for a 75-year-old male lift assist. So we're thinking sick, not sick? Not sick. And this is something that you guys go out. Is that still 50 response only? Yeah. Sometimes you could be there with this patient by themselves. So you enter to find the patient lying face down in the bathroom with no apparent injuries, asking for help getting up. Is this something that we see paramount? not a ton here. If you were to work in Norwalk or in Haven, how many times you go for those? All day. One day it was go.
Fire guys usually
Not bad. That's good. It's very working. Brothers help brothers. So this is common. When I worked in Norwalk and in Stanford, we saw this all the time. So the patient's undershirt's moist, but it's stating he has a little trouble catching his breath, and he's talking in shortened sentences. Are those things bad or good? Yeah. It's not terrible. I mean, his first thing was he wanted help getting up, so it's not really super bad, but not that tough way. But his lung sounds have rails in his faces bilaterally. So what's that a sign of? CHF, pulmonary edema. We're talking about that a little before. And so, do you guys know what rails sound like? Yeah, it's fluid movement, but you squeeze some of your hair together and twist it. It's pretty faint, but that's basically what rails sound like. They're pretty hard to hear. If it sounds really chunky, like really, really bad, that's bronchitis, probably like pneumonia. And if it's really faint like this, it's really more like a rails picture. So sometimes all I hear is that they're decreased. The lung sounds aren't as good in the bases as they are in the top of the chest. If you listen to lung sounds on all your patients, you'll be able to identify, hey, this isn't right. But if you don't listen to them that much, you're just going to think, oh, it's just my stethoscope. Maybe the patient has a larger body habitus, which very well could be, and that's going to throw off your assessment. But if you keep listening to lung sounds, you'll be able to diagnose those little things. Those are decreased. I know they're decreased. I'm pretty confident this is going to be wrong for assessment. So blood pressure, 180 over 110. Pulse rate of 92 and respiratory rate of 24. So blood pressure high or low? Respiratory rate high or low? And pulse rate high or low? Yeah, so is this common for our CHF patients? Yeah, they're very common. This is often how they present. Blood pressure's through the roof, and it just, their heart works harder to try to get them to breathe better. The harder their heart works, the more fluid backs up into the lungs, and it gets worse and worse and worse. And this is, the rest of this scenario is actually pretty common as well. You have a patient who's in the bathroom lying face down. So a lot of these patients are on Lasix. Do you guys know what Lasix is? Water pill, makes everybody pee. So it takes fluid off the lungs, well, it takes it off everywhere in an effort to try to keep their lungs clear of fluid. So it makes you pee, so they take it at night, they go to sleep, they wake up, they already have maybe urinary retention issues because this guy's 75 years old. So he rushes to the bathroom because he doesn't want to have an accident. He trips and falls, and then that's where we find him. But the reason that he tripped and fell wasn't just a mechanical trip and fall. He fell because he didn't want to pee, and now he's been lying on the ground for so long, and so his lungs are filled up with fluid because they breathe best sitting up. Often they sleep in bed with 3 or 4 pillows to keep their head elevated so they can breathe in. So this is actually a pretty common picture. So meds, surprise, surprise, furosemide, Lasix, same thing. He has a history of CHF. We're starting to narrow in on it. And he has, his differentials that he's an acute pulmonary edema related to his CHF. So again, our treatment is high flow oxygen, rapid transport, medic intercept, nitro, Lasix, maybe BiPAP or CPAP, and potentially intubation at this. So we're going to skip this. Okay, so we took a quick look at causes of respiratory distress, the treatment, the anatomy. We looked at several case studies, and then we started to narrow it down by using their patients' signs and symptoms, and then that's how they presented with their medications and history to make a difference. Okay, questions? Cool. All right.
What are some common causes for chronic pulmonary?
So a lot of salt in the diet. Let's say it's Super Bowl Sunday, they just eat a whole bag of Lay's potato chips. Water follows salt, so you keep eating salt, and the water stays in your system. You don't pee it out. And it's just over time things get worse. So your heart gets a little weaker, and then it starts backing up. You take more medications, that affects your heart from pumping as well. So these patients, over years get progressively worse CHF. And then if they lie flat when they go to sleep, that can trigger it, or if they're found down on the ground, also trigger it because they're not breathing sitting up. And so the little fluid that was sitting in this space is now covering half of their lung because they're flat.
So just going supine.
forgot about your question even though I told you everything.
That's okay. For the snowmobile injury, would the left foot have something to them?
Absolutely. Yeah, that's a great pickup. So your good lung should sound normal. Your bad lung is going to be decreased. If it's a hemopneumo like that, you're going to hear bronchi and fluid in there. If it's just a tension pneumo or spontaneous pneumo, you shouldn't hear any lung sound at all in the area that affects the pneumothorax. Those aren't that hard to diagnose because they might have a 15% pneumothorax. And so only this little area is not really expanding well. So you listen here and you have your lung sound, you listen here and you have your lung sound, you listen here and you listen here. So, yeah. Well, thank you.